Hello, exchangers of gas. Welcome to the Gas Exchange podcast, where we talk about anything respiratory critical care. Remember, the information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. My name is Keith Lamb. I'm the host, and I'd like to welcome my co-host, Thomas Piraino,
Hello again.
and our very special guest today, Dr. Brady Scott.
Hey, everyone. Hey, Keith. Hey, Tom.
Dr. Scott is a highly respected researcher and educator and respiratory therapist, and we are so fortunate to have him here today with us. Brady, would you mind just telling us a little bit about yourself?
Sure. Hi, everyone. So my name is Brady Scott. As Keith said, I've been a respiratory therapist for 25 years now. And my current role is I am a program director and professor at Rush University in Chicago in the Department of Cardiopulmonary Sciences, which is the Division of Respiratory Care. So nice to be here. Thank you.
Yeah, so Brady and I have been close friends for a very long time. I don't even know how long it's been. It's been since you were at Duke many years
I think
ago.
I've received my first email from you asking me a question about something at about 2:00 in the morning when I was in the emergency department. So that would time that out right around probably 2003, 2004.
Yeah.
Something like that.
It's been a minute or two.
Yeah. And I was at Duke University for 10 years. And I think that's, when I started getting more involved in meeting other people in the profession and traveling to conferences and stuff like that. So I think we've been friends for around 20 years, Keith.
Yeah, I can remember.
We don't look any different.
No, we don't. We look exactly
the same. I haven't aged a bit.
No. Well, Brady, we're really glad to have you here today. I think that, you're an expert on many topics, and I think that we could probably talk for a long time, but let's narrow it down a little bit to, I'm interested in your research regarding resuscitation science and probably more specifically tidal volumes during CPR. What can you tell us about all that?
Yeah. So I'll kind of back up to tell you how I got there. I've been I'm assuming most of the audience here are respiratory therapists or critical care clinicians. Like all of you, I've been in numerous cardiac arrest situations, and I've been ACLS and BLS trained my whole career. And you learn about how often to squeeze a resuscitation bag during your code. But then we are missing how much volume we're giving. And so one time I had the privilege of teaching a group of physicians, actually, was doing we were doing like a intubation airway management workshop. And before I go on, let me say that I'm not different. I was just the observer. But I noticed that during that workshop that I was assisting with, that almost every single time that we intubated the patient, when the physician grabbed the resuscitation bag, a lot of the times, two hands squeezed the bag at a rate that was somewhere, roughly counted probably around 40, because I was kind of counting it because basically they were squeezing at the point of recoil of the resuscitation bag. And so I was just, by observing this, I asked this question. If I were to have handed you a mechanical ventilator, what settings would you have put on? They're like, 6 to 8 mLs per kilogram, rate of 16, something like that. And I'm like, it was interesting to me. I'm like, so the reason that we do that with two hands and all that is because we can't see it. So we don't really know what we're doing. And we're looking for maybe the SATs to go up or whatever, or we're just thinking that we're providing patient oxygenation. But if we can see things, we wouldn't, maybe we would make a different decision. And so then I just started having conversations with colleagues, and I'm like, what do you think? We never really think about tidal volume that much being delivered during manual ventilation, and even particularly tidal volume being delivered during cardiac arrest, because we can't see it. Like, we know how often to squeeze the bag. We certainly have papers that have suggested that hyperventilation is associated with negative outcomes in certain models. So, just a lot of conversations with colleagues and stuff. And so that led us to creating a study that we are currently actually just wrapped up. We're in analysis phase at the time of this recording. And we collected actual human data on how RTs perform ventilation, both vent rate and tidal volume during CPR. So it was interesting. It was just my whole interest in this topic was finally being the observer and not the person who was doing it. And again, let me be clear. It ain't like as an RT, I was ever doing this any better. I'm sure that there's been numerous cardiac arrests that My adrenaline was also flowing, and I probably squeezed the bag too many times, or definitely have done a two-hand technique or whatever. And so, that's kind of how it all started for me. This interest in, like, what are we doing? If we had an opportunity to fix it, what would we do? And what is the right thing to do? Because I'm still not sure. I don't think we're still sure what the actual right volume is, or tidal volume is, to be delivered during CPR, and things like that. So we did almost like a proof of concept study, for lack
Mhm.
of better words. That's not what it was, but for me, it was a proof of concept. We actually collected data on individuals that were going through a mega code
Mhm.
of, the training that goes with ACLS. And we collected information with over 50 people. And we plotted the tidal volume for each individual person, the average tidal volume during the code. And that plot looks exactly what you think it looks like.
Mhm.
Person 1 gave an average tidal volume of 400. Person 2 gave an average tidal volume of 900. Person 3 gave, 1,200. Person 4 gave 200. And it was just all over the place because nobody could really tell what tidal volumes that were being delivered. Interestingly, in that study, participants did, however, do a good job with the recommended rate, the respiratory rate that was being delivered during CPR.
I've seen you discuss that data, I think, and you had that one guy that you said gave up. This guy just gave up. I can't remember. There was one guy that was way outside of the
Oh yeah,
plotted
well,
range.
if you look at the if you look at the graph, we published that paper, I think in 2021 or 2022. I can look it up, but there was somebody who did like 1,200, 1,500 on average, and then somebody over here at the end was like 200. It's almost like they were
Yeah,
whatever. It was an afterthought. Like the average tidal volume. So when you looked at the mean the average tidal volume across the entire group, it didn't seem that far off, right? It was around 600, 500, that range, which I think to the average respiratory therapist doesn't sound crazy. But I think it's when you look at the individual people inside, but at an individual level, you can see that there's quite a bit of variation. And then when we looked at this study, and there's tons of limitations of this study, it's certainly not earth shattering. It was just sort of observational and interesting. But then we started having the conversation. Well, who's right? Is it the person that averaged 600 and a rate of 10 during CPR? Was that better than the person who actually gave the 1,200 during? Or was the 200 best? Was the micro, like the small tidal volumes,
the
the better
oscillator.
way? Yeah. So then it just really sparked conversations about, like, what actually is the right amount together, Like, is it larger tidal volumes, smaller rates? Is it smaller tidal volumes, maybe quicker rates? Maybe it's just the Goldilocks. It's just enough principle, which is kind of what we recommend now, and now we go rate of 10, chest rise and fall. Maybe what's adequate. I don't know. I'm interested in trying to find that, if that exists.
There there is some data looking at tidal volume and essentially finding an optimal range essentially between like 400 and 560 for most adult patients, because there's studies comparing like small, like pediatric style, like small adult bags versus regular adult bags and the effect on how much volume is delivered. And the new AHA guidelines were just published very recently that kind of hint at smaller bags not being overly effective because the volumes are ridiculous. So again, suggesting larger volumes, but I don't know if you've in terms of like teaching volumes. And again, full disclosure, I do teaching in webinars for this company that sells this valve, but it's intended for teaching bagging technique, and it's a flow control valve. Because when you squeeze a bag, essentially you can the faster and harder you squeeze it, not only do you increase resistive pressure, which as RTs we all understand that's not what injures the lungs, but it certainly can get volume in a lot faster, which can be dangerous, right? Because if you
Yep.
squeeze fast, you get way more volume than you need to versus someone who squeezes maybe too slow. But this flow control valve, I call it the humbling valve, because when I first got it, I went to squeeze the bag like I normally would at a code, and it
And it
just
stopped you?
stopped. It just stopped me, and I'm like, so I took the valve off, and I'm bagging. I'm like, okay, and then they actually sent me like a tablet with like I have like a flow transducer like on my desk because that's just what I do when I'm bored. And squeezing the bag, I'm just like, damn, I'm delivering really fast flow rates, which is getting significant volume in there. And then as soon as I put the valve on, it forced me to slow down, and then the volumes were actually more effective. So in terms of teaching, it's like one thing to like see the number. Obviously, that's better than everything. But these webinars are mostly geared towards like fire and EMS, right? Where like they don't really have the technology that we may have available to us in a hospital setting, which I mean, I don't know anybody measuring volumes at a code, but if you were to roll that out in a hospital, you're probably have more luck than doing it in the field where you might lose the darn device or whatever. But it's interesting. I call it the humbling valve because it really changed how I bag.
Yeah.
And I'm much more consistent after. It's called force function, right? When you force yourself to learn a certain way, it really has an impact. And I was quite surprised. I don't know if you've ever used those valves.
No,
I
I'm
know they're
aware.
relatively new.
Yeah, I'm aware of it. I haven't. If it's my understanding, this would tell me if I'm wrong. My understanding of this is probably really useful in a patient without an advanced airway in place, like if you're doing bag valve mask, with
Supraglottic.
and that way we're keeping the peak pressures down so you don't have a problem with gastric insufflation. Is that correct?
That's so right
At
now,
least part of it.
the valves are intended for education. They're not really intended to be on a patient, but the
Okay.
idea would be like, yes, it would result in less resistive. Usually the demos I give you result in significantly less resistive pressure when you slow your flows down, which if you don't have an established airway is extremely important. But one of the things you do notice is that when you don't limit the flow, this is where that excessive tidal volume is really easy to get to. So for example, you
Yes.
mentioned the two-hand squeezer. Squeezing that bag with two hands would cause so much flow that it would immediately stop and you'd have to slow down. And as you
Oh,
slow
okay. That's
down,
interesting.
you
Yeah.
probably wouldn't squeeze as long to deliver
Yeah.
so
Yeah.
much volume, right? You'd be like, okay, that's enough, and then you'd stop. So like I said, it's the humbling valve. I couldn't believe how much it made my bagging more consistent. But
Yeah.
yeah, just a side note, it was something that was introduced new to me recently. And then when I started playing around with it and started doing some talks on it and seeing the data, I'm like, we're not trained. We're not trained properly. Like RTs in school. I mean, like, we were never really focusing on tidal volume at all when we were taught. I don't know
Right.
about you guys, but
No, me neither.
and it's just all these studies showing how random we are. Like you said, some
Yeah.
200 mils, some 1200 mils. Like it's so
Yeah.
all over the place and there's no consistency. And like, how do we train consistency?
Yeah, I think that was again. I think it's something we all, or at least I'm just going to speak from my own experience, but it's certainly something you just observe at the bedside, right? You go to one cardiac arrest, and it looks like somebody is like perfect, right? They're following guidelines to the T, and the next time you go in there, it's like as Keith alluded to, it's like the oscillator,
Absolutely.
Yeah.
and it's just, and then sometimes, as much as I'd like to think, I try my best to always do whatever, the right thing, whatever. But
Adrenaline takes the better of
sometimes
us
adrenaline,
sometimes.
yeah, you put the
Yeah,
two,
yeah.
I came from hospitals that were RTs intubated, so the adrenaline's going, and a lot of people are yelling, it's loud, and all of a sudden you just catch yourself beyond, those type of things. So yeah, this became an interest of mine. Actually, another little side study, or no, I don't say side study, that's incorrect, but another thing we're looking at is how lung characteristics might change the way that we deliver tidal volume. So
Yeah,
have a
stiffer
kind of a,
lung versus the compliant lung.
yeah,
Yeah, for sure.
it's a healthy study that's bench-like in its nature, that looks at all combinations of resistance and compliance across the adult-sized bags and pediatric bags. And so we're about to wrap that up too and collect the data. It's interesting what maybe airway resistance even might do to our delivery of tidal volume. You put a resistor downstream. But, so hopefully we'll get that out at some point. Let me make sure that I also disclose, I have a patent on a device that monitors tidal volume and respiratory rate, and it's not worth, it's only in digital format. I have no product. It is not being created by a company, and I'm going to be a billionaire soon, and I'll be on my
You're
yacht
like, here it
later.
is right here.
Yeah, but so I just want to make sure I get that out, because I do
piece of
disclose
paper.
that when I do these talks at conferences. But it was early on, because I just thought that, maybe as we develop this science, we'll get to a better understanding of, here's a better way, or the most likely, how do I put it? Maybe this is the best way to breathe for a patient to give them the most likely chance of success, right? If we just either slow down or speed up, or the right kind of volume with the right kind of rate, just eliminating that as a reason that somebody doesn't survive, if nothing else, right? I think we all have to acknowledge that, in certain situations, the reality exists that biology is going to win, and there's just going to be times that we can't, the patient won't survive, based on how we breathe through them. If we use 100% oxygen versus room air. But I'd like to get us to the point where this fraction of a patient, the small percentage of a patient, that maybe if we just do this part right, it doesn't impede venous return. It doesn't have any negative effects, and they can survive if everything else is done correctly. I don't see why that's a stretch goal. I feel like we could handle that one. I feel like we can figure out, okay, we got pretty good data that says we could do X, Y, Z to make sure that most of the time we are breathing correctly for a patient. I say that as a joke a little bit, kind of, because I was telling somebody about my research, and this person's a really prolific researcher. They said, why would you ever get involved in resuscitation science? And I'm like, I don't know. What do you mean? They're like, it's just, you got to enroll so many people. It's so hard to find something that may make a change. And I said, yeah, you say that, right? But I'm like, hundreds of thousands of people each year are in cardiac arrest situations. So if we can just find something that may make a few more of those folks go home, I just feel like it's worth it to try.
There's a few different models that can be utilized too. I didn't intend to, but I got involved with resuscitation research with a group from France that was doing research here in Canada.
Yeah.
And they're using the Tidal cadaver model, which is a soft fix embalming method where essentially the cadavers retain a lot of their elastic properties, and they have similar respiratory mechanics as an out-of-hospital cardiac arrest patient. And the other thing they have in common that they found in actual out-of-hospital cardiac arrest patients is that when you perform chest compressions, a lot of these patients will have the condition of airway closure. And they have done studies looking at the CO2 tracing and actually compared it to like actual cardiac arrest patients where they were able to measure the end-tidal CO2 on an actual monitor, as well as ventilation, et cetera. And one of the interesting papers that we published there was two interesting ones. One was a CO2 one where they actually feed CO2 down into the lung of the cadaver that has airway closure. And then they're bagging the patient, and you get a very distinct pattern when you have airway closure when the exhaled CO2 is coming out. And with the application of PEEP, which is something that it's so taboo, right? Like PEEP during cardiac arrest, it's like, no, you're going to affect the heart. What they found is that with a correct level of PEEP that overcomes airway closure, your tracing actually changes in a significant pattern. And so then you all of a sudden have actually effective ventilation. Whereas prior to that, as you're bagging the patient, you're not getting effective ventilation because you have airway. As soon as you release, the airways are closed and then you have trapped gas. So the application of PEEP actually changes. And they published a really nice paper showing the pattern changes and then compared it to actual patients that were almost alive. They were being resuscitated and showing identical patterns that were changing as they applied PEEP to these patients. But of course, again, this is technology that we're not often using. Usually the end tidal we're using at the bedside is a color change, maybe a digital monitor, but we're not looking at the actual tracing, right? We're not looking at the typical capnogram. So that was one of the interesting stuff. And the other resuscitation one that we did was whether or not you should stop chest compressions to give the 2 breaths or give the 2 breaths while you're doing chest compressions. And can you guess which one had more gastric insufflation?
You stop?
Yeah. So stopping and giving those 2 breaths resulted in more gastric insufflation. And how we did this study was interesting. We put a hole into the cadaver's stomach with an endotracheal tube with the balloon inflated so that it tamponades the hole. So it's held securely so there's no leaking in the abdomen. And then we have a right spirometer on the endotracheal tube. So, and then we're performing the CPR in these mannequins and bag mask ventilation. And when we compared the stopping 2 breaths versus just trying to breathe in between the chest compressions at a specific rate, a recommended rate, there was significantly less gastric insuffation. So
what was the potential explanation for that?
I'd have to reread our description. I think one of the reasons was that while you're ventilating, there's actually, we talk about this passive ventilation that can sometimes occur when the chest recoils, which kind of can help to draw the air into the proper way, like a path of least resistance. Whereas when you stop and you just squeeze, you don't have that recoil that's kind of helping to draw. Again, that's what I remember in my mind, but there's probably a much more scientific explanation.
Sure, no.
Or we straight up said we don't know. I have to reread the paper that we published. But yeah, it's a very difficult science because when you tell people you're doing resuscitation research on cadavers, they're like, wait, what? It's like, they never.
It's too late.
They never come back. I could tell you, they never come back. But it's an interest. Like we have these 2 published papers. One of them was published in a resuscitation journal. So I mean, it's
Yeah.
possible to do the resuscitation research, but you're right. Like that question or that comment that person made to you about how challenging it is because you have to wait for someone to be in a arrest
Yep.
situation. What do
Yeah.
you do about consent, right? Now, there are deferred
Right.
models of consent. If there's
Yep.
no harm if you're just collecting data, there's usually a lot of deferred models that can
Right.
be used for research
Yep.
where you approach the family and say, can we use the data we collected? So, but yeah, it is a challenge.
It brings to mind some of these newer ventilators that have CPR modes. What are your thoughts on those?
Personally, I think, I mean, I have no opposition to it. I still argue, what settings do I use? Right. So from what I can tell, it's, at least in the US that I'm aware of, it's probably less common compared to some other countries where I have colleagues that are interested in this type of thing. They seem to use mechanical ventilators during CPR and successfully. And even in the literature, there's some people describe like strategies of how to set the ventilator just based on what we currently know. I still think that we need to figure out what the best settings are, right? Like what Tom said, do we use PEEP? Do we not use PEEP? So if somebody codes on a vent, do you turn the PEEP off? Is it better to keep it on? I think we still need to keep doing this type of research to find that. So I have no opposition to it. I just don't know, if my hospital started doing it tomorrow, I just wouldn't know how to set it. I mean,
Yeah.
I would just, set it based on probably something similar to we see in the guidelines or whatever's out there, but I'm not really sure, the question is that, are those the best settings? Maybe they are, right? I had a meeting with one of my students recently and talking about this type of research and then like, what are you expecting to see? And I said, I know this sounds silly, is like coach speak, but I just want the truth. It's possible that 5 years from now, my research said that what we were doing was fine. No change. I don't know. But I'd like to think that perhaps even either in certain patient populations or certain situations that we can identify and try to maximize the likelihood of survival, or at least maximize the likelihood that the way that we're breathing is not decreasing the chance of survival.
Yeah,
I know.
we've used that CPR mode in some of the like when we would go to do these studies on the cadavers, we would do several studies all at once because you have a cadaver model, so you test one thing and then you test another thing. Like they're not going anywhere. They're not. I mean, their body's made for dedicated to science, but I found the mode to be quite interesting. A, it doesn't alarm. B, you're right. You need to adjust you need to just look and see what volumes are being delivered when they can be and what your minute ventilation is, and you can adjust the pressure. I think it defaults to whatever mode you want it to. So essentially, it's a pressure mode generally that it targets, and then it has a lower rate and a pressure target, and then you'd adjust that. And then again, if the ventilator integrated an actual end-tidal CO2 tracing, you could utilize that to titrate PEEP. But again, we don't have good evidence on using it on real patients in real time. So we don't know if that's a useful strategy, if it's going to improve outcomes by titrating PEEP according to a CO2 waveform while doing CPR on a patient on a ventilator. Like there's so many factors that, how do you study this on a regular basis?
Right. Yeah. I mean, like, for example, we just wrote a paper about this actually. One of my former students, Ahmed Al-Ghatani, who you actually met, Tom, out in Saudi Arabia when we were there, and Dr. Jay Lee, my colleague here where I work at Rush. We wrote a paper on ventilation and oxygenation during and after CPR, and I was just looking at it, and so we were mentioning that there was a paper that proposed a 6 dial strategy. Strategy include volume controlled ventilation, PEEP of 0, tidal volume of 80 mLs per kilogram with an FiO2 of 1.0, ventilation rate of 10, and then a peak pressure alarm of 60, and then switching off trigger sensitivity, and try to keep the IDE ratio of 1:5. Right. When you look at that paper, it's just based on sort of what they have put together as maybe the best case. So, I mean, none of those settings are, to me, really stand out as being bad. So, you could start at something like that. But the question is, I think that PEEP thing that you bring up, Tom, is fascinating to me because I would have never thought of that.
It was fascinating to me because I remember reading early on that cardiac arrest is a very common condition that precludes airway closure. So, I mean, think about it. You're pounding on the chest for however many minutes, right? It's not surprising that you have not only edema but airway closure. And yeah, the fact that when we're ventilating these patients, we always think, I mean, you're always told like, oh, don't put the PEEP valve on yet. Like, it's going to affect the heart. But how do we know it's not impacting ventilation in a negative way by not having some PEEP? And like, how do you select the PEEP without having any objective measures? It blew my mind when I saw the like when I was part of the work, but when the paper came out and kind of they all put it together, it was like, that's really interesting. And I'm like, no one's talking about this. I'm
It,
like,
would- it'd be,
it's
it would
interesting.
be interesting to see what degree of PEEP confers the greatest benefit, and if it's for most patients, if it's changes across patient characteristics.
Mhm.
For some reason, my mind, it made me think of like a OSA. It's almost like if you the likelihood if you put 4 of PEEP on and somebody needs 6 of PEEP, then the 4 didn't work. Because you're trying to literally, sounds like are you splinting the airway open? You're basically using positive pressure to keep the airway from collapse, right? So you'd have to find the value. And it sounds like you're saying the end-tidal waveform can help you actually find the
Yeah, it
value,
actually
correct? Is that
changes.
how
So
that
like
works?
so the closer you get to the airway opening pressure, the more the waveform starts to change. So there's like, I think I'll actually call the paper up when Keith talks again, just so I can say things that make sense. But essentially, there was like clear airway closure where the waveform was very different, and then there was when essentially it gets better as you increase PEEP, and then once you have the appropriate PEEP, it completely changes the shape. But I'll look at it because I think they described 3 different waveforms and because the other one they showed a waveform that represents overdistension. So it changes shape that once if you give too much PEEP, it actually changes the shape of the end tidal tracing. It was actually quite interesting. I'll call up the reference just so our listeners can.
But I think it's wonderful. I clearly haven't read this paper, so I'm so interested in it now. So if you can email me that when
I
we
will,
get
I
off
will,
here,
I will, and
text
I'll
me.
mention the authors too. Yeah.
But it makes me think about, as we talk more and more these days about individualized, mechanical ventilation strategies, individualized patient care. Maybe this is also another avenue where imagine a future soon that we have some device that helps us figure out how to titrate even PEEP for the optimal situation that we could be in.
Yeah.
That's cool. Yeah.
Yeah, so the paper is in Critical Care. It was published in Critical Care. It's open access, 2022. The first author is Arnaud Lesimple. So it's like Le Simple, Lesimple. And I mean, if you search his name or how to spell my name, you can find it that way. Laurent Bouchard is part of the
Okay.
paper
Yeah.
as well. It was part of the Caviar Cardiac Arrest Ventilation International Association for Research group. But yeah, they have very nice, distinct tracings of different patterns of airway closure. And then so they compare these with not only the cadaver model, but also out of hospital patients. So there's a few examples there. And there's like a distension ratio that they give. It's quite interesting. And I really feel like I should probably, maybe do a talk at this at ARC or something like that, because this is something that I don't feel, aside from you, there's not a lot of us talking about resuscitation science at these journal conferences. I feel like you're the only one that I've seen talk about this stuff at the conference.
Yeah.
And these tracings that you're referencing are all capnography tracings?
Yes. Yep. Yeah.
It's called a novel capnogram analysis to guide ventilation during CPR, clinical and
Mhm.
experimental observation. That's really
Yeah, because
cool.
they had capnography available in 202 patients soon after intubation during chest compressions. So quite a few capnograms to look at in patients, and then they compared it to this research model where they could actually replicate, because we have a known airway closure, we can easily test for airway closure in the human cadavers and stuff. But anyways, very interesting stuff.
Yeah.
That I often forget about until subjects like this come up, and I'm like, oh yeah, there's this thing that I was part of, and I always forget to mention it or talk about it. But
So
it's
you're
cool.
very, very unlikely to negate or mitigate any airway closure when you're before an advanced airway, for sure. Would you say that?
It'd be very challenging. So in the studies, they did utilize PEEP valves with bag mask ventilation and did see changes, but it's obviously way more effective if you have an airway. Established airways, like, because as soon as you put PEEP and your bag mask ventilating, as all of us know, your leaks become more challenging sometimes.
Yeah.
Yeah, it's not as
Isn't it
effective.
interesting how we keep going back and forth between how important ventilation is and how important, uh, an advanced airway is, and then back to, well, maybe the advanced airway is not the important part. the chest compressions are the most important part. Do you guys remember? And I think that's still where we are now. I think the chest compressions obviously are significant,
Yeah.
are a significant part of
Clearly, you need to perfuse parts
resuscitation.
of the body. Yeah.
Yeah, that whole oxygen delivery really, that whole cardiac output side is very important on the O2 delivery equation.
Yeah, it
Yeah.
turns out.
Yeah.
Turns out
Turns
they
out.
knew what they were talking about. didn't
Turns
they?
out the cardiac
Yeah.
output's huge on that. Yeah.
Yeah. Do you guys remember the impedance threshold device that everybody was trying
Mhm.
to get everybody
Yep.
to use a few years ago? Whatever happened to that? Do you know?
My understanding is the animal studies were interesting and the adult studies kind of, I don't think it took off because the humans, did I say animal twice? The animal studies seem to be promising, but I think the human studies didn't show any benefit. I don't remember if there was a harm or anything, but I don't think there was overall benefit, if I recall, because I remember our hospital looking at it, like a local vendor was talking about it and like trying to get us to buy in. And I was being the person I am, and I'm sure you guys are the same. I was like, do you have any paper? Like, do you have any data? Like, can I read something about this? Because you're making a lot of statements, and all the statements were based on animal data at the time. And then I
Yeah, I
think I
don't
heard
remember being
years
impressed by
later.
the data.
Oh, and I think years later when some adult studies came out, I don't. I think why it hasn't taken off because I don't think it was something that was considered effective. Again, I don't know if it was harm or anything, but I don't think there was benefits.
I never worked in a hospital that used it. What was its proposed mechanism that was beneficial?
So essentially, it was a way of absolutely reducing PEEP to nothing. So like,
Oh,
I believe that so when you squeeze the bag, you had to squeeze a certain amount of pressure to get over the valve. But I think as you squeeze, air came out and couldn't come back in. So you couldn't re-entrain air. If I'm not mistaken, Keith, does that sound about right to you?
Yeah, that sounds right.
Basically, as you're doing chest compressions and air is exiting the lung, it's removing all PEEP. And so
It was supposed to improve venous return.
yeah.
You know,
okay.
It's like,
yeah,
what if
I
we
was
got rid
I
of
was thinking
all
it was
airway
supposed
pressure?
to improve venous return, but I wasn't
Yeah.
sure how it did.
Yeah, it does it by completely eliminating PEEP. And again, based on what I was just describing with airway
Yeah.
closure, I
That's
can
the
see
opposite of what we
why
should be
in
doing.
a human like, and maybe in an animal model, airway closure is not a common thing when doing this type of research, right? So perhaps it was the airway closure that was kind of the confounder in why this thing wasn't useful, because you're not ventilating nearly as well without PEEP, and now you're completely removing positive airway pressure during the chest compression phase. But yeah, that was essentially it was a threshold device that pressure had to reach a certain threshold to go in, but then it did allow pressure to leak out and not get entrained in. So you basically eliminated all end expiratory lung volume to try to improve venous return. Yeah.
It's interesting.
You know, I think from a physiologic standpoint, we've always known that hyperventilation is probably worse for everybody than hypoventilation. And I know you guys have practiced long enough to have seen this at least once or twice, where you have a patient that gets intubated, an asthmatic, let's say, that's got bad obstructive disease, gets intubated, they get hyperventilated, they lose pulses, they get to the emergency department, you disconnect them from the ambu bag, the air comes out, all that trapped gas comes out, they finally get some of those ACLS meds circulated, and they get a pulse back. So I don't think it's unreasonable to believe that you at least have some component of that issue with a person that's already got no pulses and is requiring resuscitation. And the other thing is that acidemia really isn't what kills people, right? It's the cause of the acidemia that kills people. It's not the acidemia itself. And we've talked about how asthmatics come in with pHs of 6.9, and as long as you don't kill them with the ventilator, they'll leave in a week or so from the hospital. So if we're talking to the bedside clinician, which I think that primarily we are, right? This podcast is sort of designed for the bedside clinician. I think it's safe to say that the Goldilocks theory is where it's at, right? You hyperventilate somebody, and that's got to be deleterious to hyperventilate somebody for multiple reasons, and to maybe hypoventilate and not get enough gas exchange during a time where the patient needs the optimal gas exchange. The best that you can optimize is also true. Would you agree with
But I
that?
think, as you mentioned, Brady, the biggest limitation is monitoring. Like we're not monitoring what we're doing half the time. So there is likely is a Goldilocks zone, but how do you know you're in the Goldilocks zone if, again, the adrenaline thing you mentioned, the one hand versus two hand, again, like, are we focusing on what we're doing here? I was going to joke earlier that after we intubate, we're usually, if you're the one that intubates, right, and you had a nice, easy, smooth intubation, for the next 10 minutes, you're thinking about how awesome that intubation went. Maybe you're not focusing enough.
I'm amazing.
Yeah,
Look at
maybe you're
me.
not focusing enough on the bagging at that point. You're just like, man, that was so smooth. And then you're like, oh wait, I'm bagging at 30 breaths per minute. Maybe I
Yeah.
should slow down. But yeah, it's
Yeah, I mean, as far as think, at least right now, right at the time of this recording, Keith, I think you're right. You know, we know that hyperventilation is bad, and we also know that we also just intuitively know that hypoventilation, you know, and not providing someone enough oxygen during this state is probably not a good thing either. I know that, you know, one of the two things that I have really piqued my interest in research over the last couple of years has been what are we doing immediately during the CPR moment, you know, the time frame we're doing CPR, and then what are we doing immediately afterwards, and like this post resuscitation time. And you know, I've been kind of deep diving into this literature, and it does appear that giving 100% oxygen during CPR is the right thing to do. So in other words, there seems to be value in making sure that we're at least maximizing the oxygen during this low flow state that somebody's in during CPR. And then probably the respiratory rate of 10 is easy to remember. A tidal volume, you know, now I think if I'm not mistaken, correct me if I'm wrong, but the new recommendations really have even left target this tidal volume that it's just target chest rise and fall, because we don't really have reliable ways to target tidal volume that's on a large scale. Yeah, I think Goldilocks is reasonable, you know, breathe around 10 times a minute and then get chest rise and fall. But I think that we need to push just, I personally, my bias is strong here, that I think we need to push just a little farther to try to figure out if, if there is this, what is it you called it, Tom, the Goldilocks zone?
Mhm.
My mind, at least for some populations, there's probably some Goldilocks zone, and I
For
think
sure.
I would
Well,
like
and
to try to
it'll be
find it.
individual. It'll be individual. You brought up patient mechanics probably play a role as to what that Goldilocks will be, right? You know, obviously delivering perhaps, you know, let's say 600 mils was a good target volume during resuscitation. Well, 600 mils in someone with airway issues like COPD who may be hyperinflating that, you may just be exacerbating an
Exactly.
issue that caused the arrest,
Right.
right? So I think you're exactly right when you said mechanics probably play a huge role into what. So we can't Goldilocks an entire population. Is my point. The
I
Goldilocks is not
agree.
a
Yeah.
generic thing. It's going to be patient specific.
You know,
Yeah,
but I think until we know more, it's probably what we have to do, right? We just provide enough respiration, you know, the chest rise and fall, maybe 60 mLs per kilogram. You know, again, go back to that number you just gave, Tom, the 600 mLs. Well, is that 600 mLs on me? So I'm 6 feet
right.
tall.
Yep.
Or is that a 600 mLs, maybe a former NBA player who's 6'9", or somebody that we know who's full.
Yeah.
That tidal volume is different for them.
Yeah. These are the basics of individualizing. Yeah.
Right. So then what do we do? How do we dose tidal volume in a certain way that is going to maximize whatever it is that we're trying to maximize? You know, like, as I keep stating it, I would like to find this Goldilocks zone to reduce the likelihood of the poor way that we're breathing from someone has anything to do with their outcomes, right? You'd hate to think that because we're not doing a good job, somebody doesn't survive. You know, that we can find it. We just have to keep searching for it. So,
Yeah, all
yeah.
that certainly makes sense. Brought up, so I just want to touch on one more thing here. You brought up the 100% during CPR. Do you remember the study a bunch of years ago now? It was pre-hospital study, I think, in Australia. You randomized between 100% FiO2 during resuscitation and 21%. Do you recall that study? And they had worse outcomes in the patients that they used 100% FiO2 on, and
No.
they explained that there was some free radical. Well, we know about the free radical production with high FiO2s, but there was some sort of interplay between the free radicals and the coronary artery disease worsening.
That study was post resuscitation, wasn't it? If I recall, I
I
think it
thought
was
it
like
was.
immediately post resuscitation. Whether or not, I don't know that it was during.
I thought it was during. Maybe it was.
Because it is ringing a bell to me, and I have a feeling it was post, and it to me it was one of those things that made sense. It's like, well, yeah, once they're on a ventilator, giving them 100% just because they had a cardiac arrest before didn't make sense to me.
Yeah.
But I don't. Yeah, well, we would have to look it up.
I
That's
can
the
tell you
problem with
that
the.
I'm not familiar with it. I can tell you there's I'm convinced based on the current data that exists that this immediate post ROSC state, this return to spontaneous circulation state, I'm convinced that we need to be very mindful of how we manage oxygen. I think we need to just target normoxia
Mhm.
and not leave somebody in a hyperoxic state for a long time. I feel that that's pretty, at least it's got to be convinced that's the right thing to do in terms of the level of the evidence. But during CPR, I'm not personally aware of that study that says 100% versus room air is better. From what I have read, or the way I understand it, it appears that during chest compressions, the delivery of 100% seems to confer the most benefit.
Yeah, it sounds right. I mean, it makes sense. But I was just, for some reason, I was just kind of thinking about this other study. So that brings me
There was
to,
actually, sorry, just because I was like, I thought I saw something recently. There was actually an article published in Chest in 2025. The article I have is the pre-proof because I put it into my. I'm sure you all have pre-proofs in your collection because we add them before they're properly published. But it was a reanalysis of something called. It was the pilot trial, which was a pragmatic investigation of optimal oxygen targets, and it was post cardiac arrest, and it was essentially an SpO2 target of low, intermediate, or high. So obviously your FiO2 needs to be titrated. So these are just SpO2 targets. And I did say the interpretation was among patients receiving mechanical ventilation after cardiac arrest, use of lower or intermediate saturation targets was associated with a higher incidence of a favorable neurological outcome compared to a higher target. A randomized trial comparing these targets in cardiac arrest population is needed to confirm these findings. So this was a post-analysis of a large trial. Again, I'm just glancing through it very quickly, but
yeah. But that's titration of oxygen immediately post.
Correct. That's post. And I have a
after
feeling
CPR, we got a blood pressure
Yeah.
back, and now we
Exactly.
manage. Yeah. Actually, if I think that was, or I actually don't think, I actually know that was the paper I was made quite a bit of this argument on at the last ARC meeting because I gave this talk on, mechanical ventilation and immediate post resuscitation. So I think we just need to be more mindful about, I think the way that the guidelines state it and the way I would state it too is once we can reliably understand the oxygenation status of a patient through pulse oximetry or blood gas analysis, then we can down titrate the FiO2 just to maintain normoxia. But actually, I looked at the little line here that we added to our paper that was published in 2024. Says in a low flow state, it is unlikely that oxygen delivery will exceed demand or that elevated PaO2 will result in hyperoxia, which theoretically underlies the increased oxidative injuries observed during reperfusion. So we did approach that and just followed it up with what, the citations that support that as well. So, but again, I think that, you said targeting the average RT. I think that right now that the AHA and the European groups are doing a pretty good job of saying, here's what we know. This is the level of evidence we're basing this on. It looks like, keeping this rate is adequate, using words like adequate, tidal volume for chest rise and fall. I would imagine that once we get more of a mainstream ability to measure, or I say mainstream, a more day-to-day ability to measure tidal volumes and stuff, that we can get a little more precise in how we go about this. And those devices are showing up, right? So I did this pro-con debate with Dean Hess when we were there. And one of the things I did for our pro-con debate at the ARC meeting is I walked around into the exhibit hall, and I think I had 3 or 4 products that actually gives us the ability to measure tidal volume during manual ventilation.
Yeah,
or at least
my friend runs the company FluxMed. They make an esophageal balloon catheter, but they also make a standalone monitor for measuring transpulmonary pressure. But they have a little known side device. It's a handheld thing that reports tidal volume and respiratory rate, and even has a CO2 option, I think, on it as well, if I'm not mistaken. But it's about this big, and you just use your normal pressure flow transducer and throw it in line, and you have tidal volume and respiratory readout. So yeah, these things exist, but it's like, why aren't we using them? And I think that was your argument. I'm like, clearly we're not good at this, but like, why have we not moved forward to monitoring it? It's
why
not
are
a
we not
complex
moved
thing.
on?
Yeah.
It could be cost, and I assume,
for
right?
sure.
What do you all think?
Yeah.
Probably just cost, and right now the perceived or the lack of perceived need or importance. I think if we, and again, here's me giving my bias again. I would like to think that my group and other groups are going to help add to the literature base here, that maybe one of these days we'll discover this is really important, and hopefully we'll discover it's important. We'll see. Whatever the truth is the most important. But if one of these days we do discover that it's important, then I think these products will be more available to us. But they're there now. Like, there are devices that are currently available in the United States now to measure breath by breath delivery of tidal volume and respiratory rate during manual ventilation at this time.
Yeah, it's coming. Keep up the good work, Brady, and hopefully you'll dial into something more specific.
And for whoever's listening to your podcast, if you have any great ideas or if there's something I'm obviously missing in my research, please email me.
Yeah,
I would like to know.
yeah. Or
So,
email any of us. We
Yeah,
keep in
please.
contact with
Yeah.
each other all the time.
We do.
Make sure that you guys that are listening to the podcast, if you're watching the podcast, then you'll see the website at the end of the recording. But if you're just listening, go to www.inspire-rt.com. That's our nonprofit organization that the three of us, along with others, put together a couple years ago, that provides educational opportunities for free, and including this podcast. So go to that website. You can sign up and subscribe, and you can see other resources there that are available too. Brady, we really appreciate you. We appreciate we know your time is valuable. We appreciate you hanging out with us for an hour.
I think what most people don't understand, this is literally how we talk when we're hanging out too.
Yeah,
Literally. This is just like see us at A or C at a bar having a beer. This is the
Likely what we're
conversation,
talking
most likely,
about.
yes.
capnography is something. Tidal volume's coming up.
I'm like,
It's coming up.
what? What does it look like? Show me the shape. Tom's
Yeah,
pulling
one
it
of us
up.
will
Like,
be
what?
like, yeah, there's this paper. It's like, what do you mean? Like, hold on, let me show you how to bust out the
Yeah.
Can you send that to me?
Yeah.
Yeah, of course, I'll
That's
send it to you.
100% true.
This is literally our conversations on a routine
It is a
basis.
very nerdy conversation all the time.
I
Yeah,
love it.
yeah.
I wouldn't give
Wouldn't have it
anything
any
for
other way.
That's
Yeah.
right,
No.
gentlemen. All
I
right.
appreciate you guys having me
Thank
on.
you so
and again,
much.
if anybody has any ideas about how to be doing some research in this area, please let us know.
Yep.
It'd be good to have this conversation and move forward to build this body of data that will maybe change our practice in 5 to 10 years to come.
Absolutely.
So
Thanks for joining us.
thanks.
Thank you.